It's the AEMT lecture series. This will be video number 2 for cardiac. Welcome back, and this is where we left off here at the acute myocardial infarction. We were talking about rhythm strips. We, talked about this one being normal sinus Brady. These patients in VTAC, can be conscious, and then VFib. We know this last one down here is called asystole. So A means without, and systole means contraction. The heart is not contracting. All right. Cardiogenic shock. So we're passing someone here who is having angina. And these patients are in some serious, having a serious probably acute myocardial infarction. Okay. The problem here is the heart lacks power. It needs power to force blood through. All right. So remember, here's your left ventricle. And it's probably the culprit here. And it's failed. It's failed because a blockage has reduced blood flow and the tissue is dying. Cellular death has led to tissue death. All right. And so we have some tissue death here. And it has left us with a weak heart muscle, right? And so we can differentiate from hypovolemic shock by a few things. Chief complaint, I guess. Yeah, I mean, you need to be able, because obviously it's not going to be trauma, but hypovolemia does occur with people, dehydration, diaphoresis, right? Stuff like that. So it's definitely different than that. And we can get that from the chief complaint because the patient may be complaining of some type of severe chest discomfort. Heart rate. Okay, we can talk about this. So generally, when shock, we're going to, and especially hypovolemic shock, our heart rate will be increased. We have epi, norepi been released, vasoconstriction, and all that. Well, the heart muscle here is damaged. So the pump, remember, it has its own electrical system. So its own electrical system is going to be hurting right now. So it can ignore the central nervous system a little bit and fire at will. And so what can happen here is we might have a low heart rate. And remember, like I said, if this is your SA node, your AV node, remember you have these, let me get a different color pen so you can see what I'm talking about. Oops. You can see what I'm talking about. Okay, so SA node here, AV node. We're going to come down here, bundle a His, and then we're going to go around these Purkinje fibers surround the ventricles. And so as the stimulus moves through, it's moving through tissue. And when it gets over here to this damaged tissue, the electrical stimulus is reduced because dead tissue slows it down sometimes. And if that happens, you're going to have a low heart rate. All right. And what is that going to do to preload? Remember, preload is, preload is dependent upon two things. One of those things was heart rate, right? And then the other was EDV. And so if preload is dependent upon heart rate and we have a lower heart rate, you're not going to be getting any type of stretch out of this ventricle. And If the ventricle's already stretched as far as it can go, you're not going to get any stretch out of that. So what does that mean for blood pressure? Well, we can see a lower blood pressure in cardiogenic shock instead of something trying to compensate. Now, heart failure is going to be different. All right, you're going to see a very high blood pressure in heart failure, but heart failure is not cardiogenic shock. All right, peripheral edema. All right, so we will see this in heart failure. All right, we will see this in heart failure. And so let's talk about that for a second. All right, so peripheral edema. Why? That's what I want you always asking yourself, why? If you don't know why that there's peripheral edema, then we need to find out, because that's a major deal. I've said it again, you're going to be the highest trained out there. You need to understand this stuff, and you need to be able to direct care for the patient. All right. Here's your heart. We have your left ventricle here. It's going to be the culprit. So, more than likely, it's already preloaded out. Okay, meaning that due to uncontrolled hypertension and really high afterload, preload has been maxed. All right, so there's your stretched out left ventricle. This is full on left ventricle failure. All right, so let's talk about how you get the swelling. Let's talk about how you get this swelling. Remember the aorta comes up and wraps around. It's very important to understand how that aorta works, because again, the body's pumping against its own anatomy and against its own pressure. All right, so pressure's high. Pressure's high. Blood flow coming through here. If like I said, I didn't increase volume. Again, 1 3/4 line. You're fixing to go into a house that's burning up. Who's ever driving has got you going at 50 psi. That's not enough for an 1 3/4 line. Your stream is going to be weak, extremely weak. You're going to call back, or your officer calls back, engine 13 officer to engine 13 driver, increase the pressure on the blue line. And the driver looks and goes, oh, damn, I had that too low. Let me turn it up. So he turns it up to 80. And what happens is that stream is great now. It's a good stream. Well, same thing here. You have a very high amount of pressure, so you have a great stream. We didn't do anything to volume. We increased the pressure, and we made the stream good, right? We didn't add volume. Here it comes, the blood coming. And how's that blood coming? At a high, super high velocity. Super high velocity. And then once it reaches the smaller arterioles, once it reaches the smaller venules, right, it can't contain it. Can no longer contain it. And so we're going to start dumping plasma. That fluid's known as edema. Okay. Fluid's known as edema. Peripheral. Think about your arms and your legs. Bam, there you go. That's why you have the peripheral edema. All right. What about dysrhythmias? Well, we need to just look again at the electrical conductivity here. Here's our heart. Okay, SA node comes down AV node comes down, boom, and boom. That's what fires these ventricles to, that's what gives them the electrical stimulus to fire. All right. And so let's say we have a blockage in, or a dysrhythmia, right? So the heart here is not pumping exactly right because of a dysrhythmia. Now this heart muscle might be perfect. We might have a perfect heart muscle here. No damage, none. But if the electrical stimulus is off, it can make us fall into cardiogenic shock. Think about it like this. The light bulb works great, but you have to turn it on. If there's a problem with electricity and the current's not making it to the light bulb, it won't work. You can replace the light bulb 100 times. It won't work. Heart's the same way. Jugular vein distension, that goes back to afterload. And it's easily explained because you have your inferior vena cava returning to the right atrium. But we always leave out the superior vena cava. And that's draining blood from your brain, your head, all that up on top. So if afterload's great, pressure is high, what happens? That pressure coming down through here, man, it is coming in. It's coming in and it's backed up. And that's what's going to give you JVD, because it's your neck veins that are draining down. Crackles, that comes from the fluid. All right, so what happens is over here in the lungs, the pulmonary circulation, if I need to send this blood, so I need to send this blood back to the left ventricle, right? Sometimes that pressure is so great, right? It's so great that I'm having a hard time dealing with this. I'm having a hard time dealing with all this pressure. So it's backing up. It's backing up. So if it backs up, where does it go? If I can't get it to the left atrium, let's back up then. Left atrium. Okay, if I can't get it here, pulmonary veins back, alveoli, pulmonary arteries. Bam. It's going to back up into the right side. And then when that happens, again, fluid leaks out. Fluid's going to leak out because of afterload. And there you go. That's going to cause crackles. Crackles are specific sound for fluid in the lungs. That's how it works. Let's keep going. All right, so yeah, same initial eval and treatment for patients reporting chest pain. Okay. We're going to, like, anytime somebody is reporting chest pain, we need to check and see if we believe that chest pain is cardiac chest pain. Okay. Or we can have respiratory type issues that cause chest pain. So we need to find out. Anxiety or restlessness. Okay. Air hunger. High pulse rates. Nausea and vomiting. And low blood pressure. So all of these are specific to cardiogenic shock. And so we would treat this patient as a cardiac patient, as opposed to we try to reproduce the chest pain. So what we'll say is, all right, so your chest pain, you described it, but does your chest pain, is it more severe if you move? Is it more severe if you take a deep breath? Because that's going to focus us in on the possibility that may not be cardiac. It could be muscular. It could be muscular related. It could be respiratory related. We just don't shove nitro and aspirin down somebody's throat if their chest pain is not related to cardiac. We need to do a assessment, right? We need to check and see. Treatments for cardiogenic shock. Rapid transport to the hospital is to an appropriate hospital. We're going to give them some O2. I'm pretty sure it'll be below 94%. All right, so O2. Nasal cannula, guys. All right, most of the time. All right, for a couple of reasons. Unless their respiratory distress is severe, then it could, and it could be, then we'll go ahead and move up. But nasal cannula doesn't usually increase the patient's anxiety like a mask does. You know that, the biosystem ventilations, I hope. You know that we need to start an IV. That's something you guys will be learning to do. We need IV access for sure, because if the patient goes into arrest, it's so much nicer to have a way to push drugs than it is not to have that. If they arrest, then you got to get an IV and then push drugs. We have that IV, then we're good to go. Transport to emergency department, not just any emergency department. Not just any, but an appropriate emergency department. Okay? And then you can call for paramedic backup if available, if needed. You can treat this patient with nitro, and you can treat this patient with aspirin, just like I can. All right? The only time that I'm going to do anything different is if there's an arrhythmia. Okay? If there's an arrhythmia, if the patient's blood pressure is extremely low. Right. Other than that, I'm going to treat this patient the same way you are. Heart failure. Okay, so we're on to some heart failure. So it says it occurs when the ventricular myocardium can't keep up, right, with the return flow of blood from the atria. Okay, myocardial infarction is a big one for this. Heart valve damage, long-standing high blood pressure issues. And I will tell you this for free. For free. I normally see this on patients who have long-standing high blood pressure issues who become non-compliant with their medications for about a month. And non-compliant can mean I just didn't want to take them anymore. It could mean I didn't have the money to get them filled. It can mean a lot of things, right? But that's when this thing rears its ugly head. That's when, because a lot of these blood pressure medications treat for this issue and they take care of it. And it's when you stop is when the problem comes. Yeah, so let's do this. Let's draw this out again. All right, pumping function of the left ventricle. Okay, we're going to call this the left ventricle. OV. It's damaged by coronary artery disease, all right, or disease of the heart valves. So remember, you have your tricuspid and your bicuspid. Right, if they're not closing, then blood can leak back. Or chronic hypertension, and that's because increased afterload. Chronic hypertension, these patients' valves, their arteries and veins are less pliable, and they stay constricted, and that increases that diastolic blood pressure, and that's the problem. Heart rate increases, okay? It does. So what happens is, through this process, when I have a backup, right? My body senses the backup, right? My body senses, right, through baroreceptors that I'm having an issue pumping, right? I'm having an issue pumping. 1 second. Let's start off with a normal heart. Let's start off with what a normal heart looks like. Okay, so we have our normal heart here. I don't like that. Stand by. Stand by. All right. All right, I have a normal heart here. Here's your left ventricle. All right. So what happens is I'm non-compliant with high blood pressure medicine. Let's just say that. So the heart starts saying, "Hey, I'm really having a hard time getting this blood out." It sends that signal. And so the body goes, "Okay, I'm going to help you. I got it." And so we're going to increase preload. So here's your ventricle growing. All right. Well, what's preload consist? What is when we're talking about preload? What two things have to happen for preload to happen? Because the body said, "I'm having a hard time pumping this fluid out. I feel like I'm backing up. I feel like I'm backing up." So the best way to get rid of more fluid is to increase preload. But preload is dependent upon heart rate and end diastolic volume, EDV. All right, so we increase preload, so that means one, heart rate has to go up. We have to go up, and we have to increase volume. We have to increase volume. No problem, we do that. And guess what? It works. And we didn't even feel it. We didn't even feel this. I mean, it just happened. I mean, we're like, "Man, I'm glad I stopped taking that high blood pressure medicine because I feel great." But you don't know what's going on. This is happening. But greatness is fixing to end. Greatness is fixing to end because after this thing gets so disproportionately large, it can't keep up. We've increased the afterload because of preload. And we have so much pressure on the system right now that we can't circulate blood effectively. There's so much afterload that we've caused edema. Right? Our feet are swollen. So they'll start seeing this too. And their feet will swell. And they'll say, "Man, my feet are swollen." And they'll start getting congested. And they're getting congested because that edema now over here in the lungs is leaking into their lungs because of the increase in afterload. And so they're, I'm going to go to the doctor. I think I got, bronchitis. And they go to the doctor, and the doctor either, could care less about their feet being swollen and doesn't put it together. Send them home, give them a albuterol inhaler and some steroids. Well, that's not touching this. Matter of fact, albuterol inhaler is making it worse because heart rates increase because of preload. Albuterol, okay, we know what albuterol does. It has alpha and beta properties, and it's going to increase heart rate even more. But anyway, so here we are, and that's congestive heart failure. And that's what happens. Right-sided heart failure. Right-sided heart failure is usually always happens right after left-sided heart failure. All right, so if the right side of the heart failure is damaged, fluid collects in the body. Usually, like I said, the number one reason for right-sided heart failure is left-sided heart failure. And this is where you get showing up that swelling in your feet and legs. And so you go, well, why? I'm confused. Don't be confused. Don't be confused. So let's see. It's this one we can figure out together. All right. So remember the right side of the heart, what it does. All right. Remember what it does. So here's your right atrium. All right, and here's your right ventricle. Blood's returning from the body. Blood's returning from the body, from the inferior vena cava. Superior vena cava, and in this case, the inferior vena cava. If, like I said, afterload's really high, the right-sided heart failure begins. The left side has already started, more than likely, and it's going to lead to right-sided heart failure. And this blood is getting backed up. And this, where is it getting backed up to? It's getting backed up right here. It doesn't make it out of the body. So it gets backed up in the feet and upper extremities. Okay? But think about it. If it's getting backed up, what is it not happening? Because this is what? This is deoxygenated blood. Right? And so that's why you put them on the pulse ox and they're at 57%. You're like, God almighty, is that right? Yeah, it's right. That's how hypoxic they are. And gravity. Gravity is the reason why it's always in their feet, because gravity takes that fluid down. Okay, that's not too hard to figure out, right? Because if this is not working, you can bet this isn't working either. So let's say you have 100 a healthy heart. You have a 100% contractions. Contractions at 100%. These folks are contracting at about 50% of the normal contraction. That's significant. That's significant. Orthopnea. What does ortho mean? You guys should know ortho, what it means. Because a lot of y'all thought it meant bone. It doesn't. It meant straight. Straight. And pnea. Okay, breathing. So what happens is when these folks, instead of, when orthopnea means when they're lying flat. Man, I hate this pen, guys. We'll see. Wish Chief Roberts would buy me a new one. But, it's not going to happen, guys. All right. Orthopnea. So, not too bad standing, right? But lying flat, not going to happen. These folks got to sleep elevated, right? Or they got to, sleep in a chair. That's usually how you know when it's really getting bad. That's usually when we're called. The agitation comes from hypoxia. Hypoxia. It'll change your mental status. It'll make you angry, make you agitated. You already talked about how the distended neck veins work. I already talked about the edema and the pedal edema and the reason why that happens. Accessory breathing muscles, yeah. So they're going to be using their everything to breathe because it's the same mechanisms in place. If all of this is happening, they're probably acidotic, okay, and they're probably they are retaining CO2. It's going to increase respiratory rate. And they're drowning. And you'll know that they're drowning. Fluid is drowned out the alveoli. So if your alveoli is here, okay, and then you have your blood flow coming past alveoli, your capillaries. But then, through all this high afterload, and I start covering up the alveoli with fluid, what doesn't happen? What doesn't happen? A gas exchange. There will be no gas exchange. Luckily, we have lots of alveoli, but gas exchange is going to be hampered greatly. No gas exchange, none. Crackles, already talked about that. A productive cough. And if you say, well, what does it look like if you're coughing up something? Sometimes they'll describe it as a pink sputum. Textbooks think they do all the time, because if you get a question that says patient's coughing up pink sputum, you can bet it's going to be congestive heart failure. All right. Right ventricle failure related. Delayed capillary refill time. Well, sometimes it can be, but most of the time it won't be. And the reason why I say that is because these patients will be extremely hypertensive. And why? Well, right-sided heart failure. Okay, so if the right side, if we're theorizing here, okay, we're theorizing. Here's your left ventricle. What's going on in the acute patient? Well, the acute patient, the left ventricle hopefully hasn't failed yet, and preload is at its best. I mean, it's working, right? So when we increase preload, we increase heart rate, right? And we increase blood pressure. All right. Afterload. All right. So when we talk about afterload, these vessels are very constricted. Very constricted vessels. What's that mean in blood pressure? What's that mean in blood pressure? That means this. 220 over 162. That's what that means. And that's common. That's a common blood pressure for someone with right-sided failure. And that's how you know, too. If you're trying to figure out if you're dealing with a patient with asthma or a patient who's in congestive heart failure, palp their blood pressure. You don't even have to take the full blood pressure. Just get the systolic. It's going to be high, guaranteed high, and you'll know it's not asthma then. Treatment of right-sided heart failure. So, yeah, vital signs, obviously. Monitor heart rhythm, absolutely. Administer oxygen is needed. It's going to be needed. These are patients going to be non-rebreather while somebody's setting up the CPAP. Okay, we'll practice with all of those. Yeah, all right, so man, I'm telling you, my career, this is definitely an ALS call, because they do want to remain sitting, and they do want to remain upright because they're drowning. I promise you, that's what they feel like. They're drowning. They're anxious and they're drowning. And so what it takes to transport this patient safely is some narcotics. That's what it's going to take. Okay, so afterload's going to be high. Your patient's blood pressure is going to be through the roof. I had to pause you there for a minute, guys. I'm sorry if I lost my train of thought. We were talking about the CRTs being delayed. And we talked about these patients do want to keep setting up. So, and the CRT is not always true. That's where we're at. We've talked about why the fluid passes through the walls of the capillaries because of afterload. And yeah, all these are reasons why you would have a failing left ventricle or right ventricle. Heart failure can definitely be caused from an MI. A pulmonary embolus, absolutely. It's weird when you see somebody with a PE, a true PE, because you won't see the blood pressure through the roof. And you won't see pitted edema. And if you do listen to lung sounds, they'll be clear. But they will be telling you in complete sentences that they can't breathe. And it's a weird thing to see. Hypertension, we already talked about it. Cardiomegaly. Yep. And that's an enlarged heart. And it's usually enlarged because of preload. Okay. Next. Oh, sorry. Yep. Maintain the airway. Call for ALS. We're going to give them, well, I mean, you can do a lot with CPAP. But my drug of choice there is going to be nitro. I want to vasodilate them. Hypertensive crisis. Yep. Any systolic blood pressure greater than 180. Systolic or greater than 120 diastolic. And if they don't have, respiratory distress, that's good. We can treat that. AAA, an aortic aneurysm, weakness in the wall of the aorta. Definitely a problem. You know about those already. We already know how to do an assessment for that. We know about these. We know about you should already know. You're going to know how to complete an assessment. I'm not going to treat you guys like you're not EMTs, because you are. If there's something in here that I can add to this, I will. If there's something testable in here, I will add it. Well, if it's something testable, and you already retain the knowledge because of your licensure, no. If it's something simple, then no. I'll remind you of stuff when I see it. But if somebody's not breathing, to open their airway. If somebody's not breathing, put oral airway in, to bag them. So I'm not going to waste your time on that. Let's talk about this. Gain IV access as long as it doesn't cause a delay in transport. Well, okay. Yes and no. Trauma, all day long. All day long. If you have a patient who you put on the monitor and it shows an ST elevated MI, yeah, don't screw around trying to start an IV on the scene. If I have a patient who's playing with chest pain and I don't see necessarily ST elevated MI, stay in play. Stay in play, because you want IV access. If something happens, you need IV access. You need to assess your patient. Taking the emergency to the emergency room is unacceptable. You're better than that. You're going to be trained better than that. I see it happen all the time at work, my part-time, and I say it to them sometimes, and they don't even understand what I'm saying. Thank you for bringing the emergency to the emergency room. What I'm meaning is there's a way, as a medical pre-hospital care true professional, to present your patient to the ER. And life-saving techniques that are under your scope of practice that you fail to perform because you think it can be done better at an emergency department is anything but being professional. You're trained, you're trained, and you're going to be trained to respond to an emergency and to handle that emergency in a professional manner, and to provide skills that are life-threatening, that increase the patient's chance of survival. If you're just bringing them to the ER, right, and you didn't do the care that you could have done, then you're increasing the mortality rate. That's what you're doing. You will be given aspirin, you will be given nitro, and you know why. Because if we can oh, that's the wrong one. Bam, here. All right. If you have a coronary artery, right? And you have a blockage right here to circumflex, which is a bad day because we have 2 major arteries that are blocked. Okay, and we give nitro. What's that going to do for us? Well, it's going to make that clot. It's going to allow that blood flow to get through. Here's your clot. Nitro is going to allow that blood to make it through. It's going to dilate it just enough to where we could get blood around it. And then we're getting some type of oxygen to that heart muscle. And what you're actually doing is preventing cardiac arrest. Because once that muscle gets so irritated and necrotic, it can happen. You know about pacemakers, you know about defibrillators. You already know about AEDs. Yeah, you've all are American Heart certified and CPR healthcare provider. And that's it. We'll go over 12 leads in a lab. Okay, guys, that's going to be it for the cardiac chapter. I hope it helped. Keep studying away, and we'll see you guys on the next video.